All right, thank you, Courtney. Um, it's great to see everybody. There's always some new faces potentially in the crowd, so just quick introduction. I'm Keith Coker. I'm an emergency physician at University of Michigan, along with Courtney, one of the medical directors of Medic. Um, I've been with Medic from the beginning. So Michelle Nypaver, who's actually in the room today, was the original pediatric co-director. So she and I launched Medic 10 years ago. And, on the 10-year anniversary, we thought it'd be nice to do a reflection, kind of timeline of how Medic evolved over time. Um, just kind of to preface this with a few thoughts, as I think about it. Uh, you know, One of the things that I think we really hold dear is the trust that all of you give to us. And certainly in those early days, Medic was more than anything just a promise of what it could be. And certainly really acknowledge, the kind of trust that those early sites and champions put in us as we started this program. And I think the other thing that we pride ourselves to the best that we can is to be as responsive to the needs of emergency medicine, the needs of emergency departments around the state. And you'll see kind of over this 10-year timeline that we had to go through some crises together. So we'll talk about that too. So here's how we started. We had 10 sites join up, many of which are still, of course, in this program. There's a couple that aren't. We'll talk about that as well. But these are, really our stalwart legacy sites who joined from the beginning. The first collaborative meeting was in March of 2016. This was in a Blue Cross Conference Center, kind of in the Wixom Novi area. I think we had like 30 people like in the audience at the time. The speaker was David Miller. He was the medical director, like kind of my role for the urology CQI called Music. And he talks about, kind of the promise and the vision, the framework for CQI, since it was all kind of new to us. David Miller is now actually the CEO of Michigan Medicine Health System. One of the things that we had to work through early on when we started out was, how to structure some of our quality initiatives. We started out with really three. So the head injury measures, pulmonary embolism, and chest x-rays for respiratory pediatric conditions. And one of the early things we had to think through is like, how would we hold ourselves accountable for those decisions around head injury? What was the evidence basis, to make those decisions? I think it was pretty clear, like in the pediatric population, that PUCARN was the most rigorously developed clinical decision rule. But it was less clear, to be honest, in the adult population. There was like several rules out there, to be honest, that were out in the literature. Um, the New Orleans criteria, Nexus, the Canadian rule. So we actually spent that first year, really digging into the literature and trying to understand like which one made the most sense to us, and eventually landed on the Canadian CT head rule. And in 2017, at one of our collaborative meetings, we had Ian Steele actually come and talk to us about this. So maybe that name doesn't ring a bell, but Ian Steele, he's a Canadian, and has basically made a career out of creating decision rules. And so was the one that really was the person leading the Canadian CT head rule study development. But he's got a lot of them. The Canadian C-spine rule, the Ottawa ankle rules. These are all Ian Steele's behind the scenes on that. And I definitely remember him being a very like outspoken person at our meetings. One of the early things that we also was working on is a program called Empath. This was focusing on that, disposition, hospital discharge, decision-making node that we all confront, every day in our work. And I think eventually kind of evolved into the later stages in our development with that chest pain quality initiative that we have today. So the next 2 years saw us increase in size, double in size, added 9 more sites. Again, many of the ones that have been around, the room for forever, it seems like to me. Some more things that we started to work on. This is the first time we got VBR. You had to meet kind of certain criteria as a CQI, get big enough before you could be part of the VBR program. This is the first time that pediatric chest X-ray and that PE measure were in the P for P for the first time. This is the first time I talked about the case for PE, although I'm sure I've done it many more times, but at least in the collaborative meeting, that's the first time we really talked about that. One of the speakers we had that year was Peter Diane. So he is a pediatric emergency physician and researcher who is part of the group that developed the PCARN rule. And so he talked about how to implement those kind of decisions into daily practice in children with head injuries. It's also when we started to talk about unblinding data within our collaborative meetings and ultimately made the decision that we would do that going forward in 2018. The next few years saw us grow again. We added another 8 sites around the state, getting toward 30 sites in total. Talked about balancing measures for the first time. Had another Canadian come and talk to us, Terry Klassen, who is also in this business of knowledge translation within Canada, sort of with a focus on pediatric emergency care. One of the high water marks, at least for me, was we had submitted an abstract to SAM on medics' early work, and it was chosen as a plenary, which meant that we got to talk about abstract in a room, with 100 people, learning about sort of our early success. And then 2020 was a pivot. This is code word for global pandemic. This is the pivot. And you can see, this really influenced what we were doing within Medic. I can still remember kind of these moments in March. We're getting prepared to have an in-person cloud-wide meeting, and we basically kind of canceled that last minute. We all learned how to do Zoom. We developed more of a social media presence, at least in Medic, Twitter and YouTube. But we really felt that there was this need across the emergency medicine community to be a convener, to respond to the crisis. And so we had 4 town halls and some virtual grand rounds, really focused on things like, what do we do with PPE? How do we conserve PPE? How do we think about care for children with COVID? How do we support the workforce? How do we think about wellness? How to take care of, respiratory distress in folks with COVID. Remember proning, remdesivir. I mean, these are all the kinds of things that we're talking about, at these virtual meetings. We also paused, many of our quality initiatives in that moment. You put pulmonary embolism on the back burner, pediatric chest X-ray on the back burner. It was really complicated to know how to care for people with respiratory complaints in that moment, particularly with risk factors related to development of blood clots from COVID. And so really sort of put that on the back burner for actually a couple years. We eventually got back to having meetings, but they were all virtual. In fact, we didn't have another in-person meeting until 2022. Had a meeting in August that was, the replacement of that canceled meeting in March, actually with Jeff Klein talking about pulmonary embolism. Again in November, we had Simon Mahler. So this is an emergency physician and researcher who's been at the forefront of developing the heart pathway and really sort of putting the evidence into place, supporting that work. And we had, launched several work groups around this. One of the things that we done early on was a successful work group on pulmonary embolism. Actually, Seth Krupp was the leader of that work. And we, struggled, I think, in that moment to really understand, like, well, what are yes, we can sort of measure diagnostic yield, but what are the kind of steps in between that in a standardized way? Some sites have algorithms, some sites don't. How do we kind of fill in those gaps? What might sort of best practice look like for emergency medicine that we could stand behind, from Medic? And we did a similar thing with chest pain. That was a moment when I think we were all learning about high sensitivity troponins and how to integrate that into the practice and care of individuals with chest pain. The next 2 years saw us grow again. Now we're up to about 40 emergency departments. This is when the ECS group joined Medic. For us in the coordinating center, there was a lot of transition in 2021 as well. We shifted our data vendor to Arbor Research. So this is where we went live with MedicLink. This is also when we were able to access Tableau as a reporting platform, which gave us a lot more flexibility and control over the kinds of reports that we can provide you. And really, I think, allowed us to better customize and tailor that kind of reporting to all of you. This is also the year that we lost many of the DMC hospitals, all the Beaumont hospitals, and Hurley. Really as a direct result of the COVID and the financial pressures that those health systems and hospitals were under. And that's one of the repercussions of the COVID years for us. One of the speakers that we had at one of our meetings in 2021 was Jonah Khaldun. So that name may be familiar to you all. She was the chief medical officer for Michigan, the state of Michigan, during the pandemic, and sort of rose to prominence as a result of that. She's an emergency physician. She was actually working at Ford at the time. And she talked to us about some of the disparities that I think, are a lot more front and center in that moment, around the pandemic. In 2022, we developed the initiative around opioid naloxone. And to be honest, there was a bit of a runway into that work. I think one of the other things that was going on simultaneously during the COVID pandemic was this recognition, I think in particular, that the opioid epidemic was really getting exacerbated, perhaps because of social isolation, reduced access to care, overdoses and deaths were rising during the pandemic years. And so we, like a lot of people, responded to that crisis moment as well, thinking about what we could do in the emergency departments, thinking that harm reduction was something that we could take on, and implemented this work around naloxone. As I said, 2022 was the first time we went back into person after the COVID pandemic years. And this is also when we were focusing, as a strategy, some of our P4P efforts. Previously, we had done an all-in for head injury P4P, and this year we did an all-in for kids P4P because of the success that we had with the all-in for head injury P4P. One of the things that also was happening kind of in a crisis moment in 2022, I don't know if you remember this, was the pediatric respiratory surge that kind of happened really early in the fall, peaked into the winter, where we're seeing a lot more children coming in with respiratory illnesses than usual. And, we actually had a virtual town hall that we hosted, in response to those kinds of concerns. The next 2 years saw us grow to more than 60. This is when all the McLaren sites, I think in particular, joined. Few things from 2023. We had some excellent speakers come and talk to our collaborative meetings. Elizabeth Samuels is an emergency physician, expert in harm reduction. She was talking about the opioid work. We're partnering as well, more formally, with this program called OPEN. It's also the first time we had an in-person abstractor meeting. Also in 2023, Todd Florin came and talked to us. He's a pediatric emergency physician in Chicago at Lurie Children's with a research interest on, how do we go about, diagnosing, or when do we need to worry about the diagnosis of pneumonia, specifically as it relates to when to get a chest X-ray, and talked about, it's not so much just about the chest X-ray that seems so simple, but the fact that maybe you think you see pneumonia, and now you give antibiotics, and some of the repercussions of all that. It's also the first time that we did the annual top docs and top sites in 2022. We also had our first joint collaborative meeting with the hospitalist HMS group on sepsis. And probably most of you just remember that the parking was terrible. But it was a great meeting. In 2024, this was the year that we launched the pediatric readiness work, the HIV screening work. One of the things that entered the literature was a choosing wisely recommendation for pediatric emergency medicine, which Michelle Nypaver was part of. And one of the recommendations was the pediatric respiratory chest X-ray work. And I think it was inspired a lot by some of the things that we've been doing in Medic and sort of demonstrating that this was important. And then we grew again. So these are the last 2 years. We're now up over 70 sites, now represented in the Upper Peninsula. And in 2025, sad that Michelle Nypaver retired. Talked about exploring disparity opportunities within our data. This was back in the fall meeting. Had another collaborative meeting, joint meeting, which is with the bariatric surgery group. It was a little bit of some like oil and water, but I think we figured it out, and there was definitely enough parking this time. And now we're here. Courtney Mangus joined as the new co-director. We're launching the Mystic stroke work, which I know for many of you in the room is still in the back burner, but for the Courtney Center, it's front and center, brick by brick, building the infrastructure for that work, and something that we'll be talking about for sure over the next year or two. And now we're here. We're in June. We're at the 10-year reflection. I hope you get a flavor for what I was saying in the beginning. So the trust, that really you've given us to be successful, our need to be responsive to all your crises moments, as an emergency medicine community, and responsive to you all's needs in those moments. One thing I want to just sort of pause and make sure of, certainly if there are any thoughts or reflections in the room, you're welcome to give them. But also, if you think of something and you have a story to tell me, please pull me aside at lunch or on break and, give me something from the past, that'll make me laugh. So I'll just sort of pause there and just say thank you, for the last 10 years. In the afternoon, we'll talk about the future 10 years and what that can look like. But, just really appreciate and grateful for all that you've done so far in this room. Courtney, I'm going to hand it off to you so we can talk about the present.
All righty, everyone. We're going to delve into the QI impact and greater impact that Medic has had this year and really over the last decade. Kind of a retrospective here, looking at some of our more enduring quality measures, starting with adult minor head injury, and just looking at the trend here over the last decade and the improvement that we've shown as a collaborative. This is representative of all sites through all time through just March of this year. And you can see we've been able to avoid low value care, avoided head CTs in patients that probably didn't need them, over 34,000 instances, which translates to almost $32 million saved. So really great work on this initiative. We've come a long way. PE, the thorn in everyone's side. Obviously, I think the PE measure is a great example of how QI is often not a linear process, and sometimes it's one step forward, two steps back. You can kind of see that a little bit with our trend here. It's always a work in progress. Nevertheless, again, avoiding over 1,200 CTs and saving $1.69 million is something we should be proud of, even if it isn't reaching the goal that we have established for ourselves. So more on this to come. Looking at low risk chest pain, I think the group started pretty well with this at 86%. And we've really neared almost a ceiling here with 98% of patients with low risk chest pain being safely discharged. It's quite a bit of savings, almost $150 million and almost 10,000 patients who've been affected by this initiative. So really tremendous work here. Looking at naloxone distribution, I think about this as almost, over 4,000 lives potentially saved or people given second chances based on distribution of these kits to people who are at risk for harm from opioids. So this, of course, is in partnership with Open. There are 21 and counting naloxone vending machines installed in EDs and hospitals and clinics across 6 different health systems. And we'll probably never really fully appreciate the full impact of this measure, but it's obviously a very important one. Looking at smoking cessation counseling for adults with COPD, over 2,700 instances of counseling documented over the last 3 years. More to come on this, but this year the measure update will also include adults with asthma who are eligible and should be counseled on smoking cessation. And we have 21 EDs participating in this VBR opportunity across 5 health systems. Moving on to some of the pediatric measures, looking at minor head injury, as Keith mentioned, this initiative was really informed by the very robust PCARN head injury rule, and we've made a good dent in the number of children who were able to avoid scans that didn't need them and could safely avoid a head CT for minor head injury. Looking at the savings here, 1.75 million. And, while we'll never know again with this measure, probably some instances of cancer that have been able to be avoided by sparing young children radiation. We know they're particularly sensitive to that. Looking at pediatric chest x-ray use, I think this is one of Medic's greatest success stories. Dr. John Greco and many co-authors in the room, we recently published this data in an abstract manuscript in pediatrics, but really just a tremendous year-to-year improvement on reducing routine chest x-rays for children presenting with common pediatric respiratory illnesses. Moving on now to the Medic Data Registry, which is growing by the day. 15 million total registry cases over the last decade, which equates to 5.7 million unique patients that are captured within that registry in the last decade. A lot of people in Michigan affected by what we do. Here's a look at the Medic registry cases by zip code, obviously clustering where our sites are and have been for the last decade. But it's not just Michigan. We have zip codes really from all over the US, Midwest and Florida, kind of pulling up the ranks here in terms of patients and cases we have been impacting. Looking at the providers captured within our registry, and providers again are identified by their unique NPI. We have almost 9,000 unique attending physicians throughout the last decade in our registry, and 123,000 unique ED providers. So our advanced practicing practitioners all captured there, and the number of VBR eligible physicians here shown on the graph, up to over 1,300 now. This number really strikes me in looking at the number of cases that have been abstracted over the last decade. 1.78 million cases abstracted, really reflecting the tremendous amount of time and brain power that goes into this operation, and the abstractors who really support this work and really couldn't obviously do any of this without them and without the information they bring from their abstraction. So in recognition of this, we think it would be fun and appropriate to highlight some of the longest serving abstractors here. Coming in at fifth, Heather Ferroni from Henry Ford, 55,000 cases. Amazing work. Andrea Millard from my Michigan, 56,000 cases. Laura McLaughlin, almost 62,000 cases from Corewell Health Lakeland. Kristen Watson, 64,000 cases from Children's Hospital Michigan. And far and away, Nancy Radovic, Children's Hospital Michigan, 85,000 cases abstracted. Really incredible work. Thank you for all that you do. Looking at the Medic website and materials available there, in the last 5 years, we've had 34,000 users visit our website and almost 150,000 total Medic materials downloaded over the last 5 years. The toolkits, the information, the resources that we have to help everyone do their job to the best they can. We hope that that's helpful, and we see that being downloaded not only in Michigan, but also throughout the country, as far away as Washington. We hit Texas. These are the top users of our website. We also received some international traffic. Canada, of course, and Brazil, but a lot in Europe as well, and Asia. So, and Australia. Do we hit every continent? Almost. We'll get there. Looking at academic productivity, we've had over 20 manuscripts published using Medic data and Medic contributors. We've had 25 plus press releases or news articles featuring Medic and Medic's work, and then over 40 posters, abstracts, and presentations presented at conferences and national meetings. Collaborative wide meetings, one of my favorite parts of being involved in Medic, have taken us all over the beautiful state of Michigan, as far north as Gaylord and off to Grand Rapids and the West Coast. Lots of meetings here in southeastern Michigan as well. More to come on those. I think more beautiful sites to see, and maybe the UP one day, who knows? We also, as Keith mentioned, have had plenty of expert speakers and panelists come to us from the Midwest, 2 from Canada, as he mentioned, bringing their expertise and wisdom so that we can learn from them. Site presentations, if the collaborative wide is the hallmark and highlight, I think this event within the collaborative wide meeting is often the highlight for a lot of people. The site presentations, learning from individuals and groups what you do and how we can translate what you've learned into our own sites and quality opportunities. Is just really a tremendous part of the collaborative, and I know everyone appreciates it when we can learn from you all. So lots of site presentations, again, with more to come this later this morning. We've also had collaborations with many of the other CQIs within the portfolio here, including Open, Inhale, HMS, the bariatric group, and develop some meaningful relationships with those folks along the way.